Thank you, sir. Okay. Welcome back. Welcome back. So this is a fun program in the fact that you get to meet more of my family. Not that you'd ever meet me again, who knows? But I always like to try and go ahead and make a connection. And one way, shape, or form, you'll not only see members of my family, but probably friends of my kids and stuff like that as they've grown up. I do have two twins that are both 24 right now. Two twins, like that's an oxymoron, right? I have a set of twins, two, boy, girl. They are both 24, and then my youngest is 21. But like life, many of you may have been in the same situation. Anybody else have kids in here? Okay, so about half, maybe a little less than that. And then, of course, everybody that hasn't, how many times have you interacted with pediatric patients? Often? Let's rephrase that question. Everybody, how often do you moderately, mild, moderate, or all the time work with pediatric patients? First, we'll go with mildly. Moderately. It's all the time. Really? What do you guys do? Okay, patients. You work with Boy Scouts, so you work with young. I get that. Oh, okay, at camps. Understood. Okay, that makes sense. And you're in the field as well? Excellent, excellent. Okay, so generally speaking, and I don't know how this happened, by the way. Generally speaking, what is it? So we're going to talk about how kids learn, and this is a prime example of when I started thinking I should probably not be saying yes or no to my kids that greet me at the door and say, "Do you want a beer?" That's called conditioning, and I stopped that when they were 10. But there we go. So I guess the next question is, now that we kind of got a census of where you guys are at, is why do kids scare us so much? Why do they make us nervous? You see your child in every patient that you every child patient that you come across, and you're not a nurse? Okay. So did you say you were right? Did you say you were also a mother? Okay. All right. I hear you on that. As a medic, I hear you. What's ironic about it is my wife, who is a nurse, there's a disconnection. There's a disconnection. Everybody in the neighborhood can come up to us and say, "Oh, my son or daughter has a problem. Will you have your wife look at them?" My wife doesn't work in the field. She works in the hospital, but okay, whatever. Yeah, sure. And then when my kids get hurt, she loses it. She can't think straight, and then she comes to the medic to say, "What do we do?" And I do what she tells me. So we put an ice pack on it and tell them to be quiet. No. So what comes out of your mouth? Rub some dirt on it. Yeah. So they make us nervous. Why? You said your kids. Yes, ma'am. Because they compensate and compensate till they can't compensate anymore. I agree and disagree with that statement, but I'm not even looking for the medical reason. Yes, ma'am. The participants said that they have a whole life to live compared to the elderly where you don't care as much because they lived a good life. So there's a couple hands over here, ma'am. They can't communicate. That's good. One reason. Yep, sir.
Volunteer agency, we run 140 calls a year, and 2 to 3 of them are pediatric calls, so we're just not. It's not in the repetition. We're not used to seeing it.
Understood. Yeah, low call volume, which means your percentage of pediatric patients is even less. Low exposure. Good. You had your hand up.
Anytime I have a kid patient, I have kid patients.
We're going to talk about that, having two patients, the parents as well as the child. Yep,
Drama.
the drama.
Kids are more, they're screaming about everything.
Yeah, and I want to take, oh, I'm sorry, go ahead. I'm sorry, what the parents? Hovering parents, increased liability, very similar to what he said. We're training to protect our young. Yeah. So these are all, oh, I'm sorry.
A lot of times when we have patients, we're looking at what their history to lead us to where we're looking for. And there isn't a history.
Correct. Yeah. Well, with the majority of the traumatic cases, you're right. There's no history with pediatrics to lead us in the direction of what medically could be wrong with them. But there's some congenital issues in some patients. Yeah. So this is great. Excellent, wonderful feedback, and I appreciate that. I really like the fact that you mentioned, repeat it again, the drama that comes with it. That's kind of something that I think is kind of relevant in the fact that they are so vulnerable. They haven't done anything in their lives yet. So for us to go ahead and see something medically or traumatically wrong with these patients, it kind of pulls on our heartstrings a little bit. And that's understandable. But really, you know, if you think about it, and I'll go back to what you were talking about with your kids, if you have a niece, you have a nephew, you have somebody or your own kids, what have you, many times it relates back to that. And because of the innocence of the children, you feel like there's such a victim, maybe perhaps more than the adult, if the same thing were to happen, that you say, oh my goodness. And I got to be honest, folks, this is the sympathy versus empathy line that you're crossing. Because when you get sucked into feeling that bad about them, you're not thinking as straight and you're losing control of the situation. So, and I'm not saying it happens to everybody, but it tends to happen. And that's something that we got to be looking out for. We need to remain empathetic, and we need to remember that this stuff happens every day to kids their age. This has happened before. It just doesn't happen as often. Yes, sir. Yep. They're seriously hurt. And there's Brewy or something, yeah. Yeah, it is scary. And going back to the points of low frequency, as well as kind of mentioned with shock that we're also going to talk about, it brings the pucker factor I talk about a little bit more up there. But the funny part is about it, we really don't need to be. We don't need to be. We choose to be, as a field, I'm saying, okay? Because if you know or expect certain things to happen, they're going to happen. It's just the fact that we don't train on that all the time. But this is why we're in programs like this today. This is also why there's other programs out there. I'm going to skip ahead to here. Pediatric Advanced Life Support. Who's taking that? Okay, did you take it because you're a medic, or did you take it because you were interested? Both? Good answer. Yeah. Yeah, it is interesting, but do the BLS providers in this room know that you can take PALS? You can. So, and it's recommended that anybody take it so they can understand a little bit more. In New York State, we have a whole bunch of other resources available called TRIP, and that's kind of neat. It actually seems to be fading out because of all the other medical programs coming from MC. So this is something that I believe is national, but I definitely know that PEP is a national program as well, and BLS providers can take. This is designed for ALS and BLS as well. And that's kind of fun because they have equipment galore that you can play with and understand from both perspectives. So I'd recommend that as well. But Toys R Us, just remember, even though it might be low frequency and you may not feel as prepared as you should be, fix your attitude on that. Be positive about it, take it on as a challenge, and see what happens. Because the way that everybody gets to the scene, you might have the motherly senior member or fatherly senior member take the call anyway, and you can learn from that, which would probably lower the tension about it, but at the same point, you can go ahead and pick up key facts on that. So attitude is everything when it comes to PEDS. And let me ask you, if you come onto a scene nervous in hell and with a straight face or kind of a really deep concern face coming into this mother, father, patient situation, is that going to be more comforting? Or is it going to be a little bit more comforting to give a half a smile and say, I got this. I got this. Because one, you're going to go ahead and interact with them. You do that for every patient. Two, you're going to get them to the hospital if necessary. And you do that for every patient anyway. So you almost got the game licked before you can even figure out what's wrong with this patient. However, parenting isn't for everybody. And because parenting is not for everybody, sometimes providing care might not be for everybody, to pediatrics might not be for everybody. So do feel the need to rely on your team as well if you can't take the lead, okay? Rely on your teammates as well. I'll get to my career in a little bit. Let's go over some of the stages of birth. So the stages of our kids. Oh my gosh, what is the name of this chapter? Infancy. I'm blanking out here. Yeah, no, we're going to go over all the different. Thank you. Lifespans of the pediatric patient. Having a brain fart here. And we're not only going to identify with pictures, but we're also going to go ahead and discuss some of the major issues or concerns with pediatric patients. So first one, neonate. This is my son, my youngest son, who's now 21, Matthew. He's born in June 25th, as a matter of fact. So he wasn't of that year. So he was not too old in this picture, and we went to a picnic. So. But that said, he doesn't sleep that quiet anymore. His nickname is Cloudy. Very successful undergrad student, and he's just so flighty, we named him Cloudy. What are we concerned about in these types of patients? Breathing, oxygen, those are more like treatment and evaluation. You're right. I'm not going to say. Okay, well, and hopefully with prenatal assistance that we're going to know if there's anything majorly going on with congenital issues. Okay, but they're out of the womb at this point. Okay, we're not worried about serious cases. I'm talking generalities. You come up to this patient, what are some of the things going to be that you're concerned about and or want to know about? Were they what? Were they premature? Okay, good. So you're looking for any, love it. Any difficulties breathing? Perhaps I'm not wording the question correct. Okay. Past medical history, was there any birth issues? No, there wasn't. Okay, you're going to do that from the door, and we're going to get into the treatments as well. I'm going to give this one away a little bit only because I want to keep going. Are you concerned about their weight at this stage? Yes. Why? After they gain back after they leave the hospital. Are you saying they have a bunch of water weight once they're born and then they lose weight and then they're supposed to continue to increase in their weight? Yes. Developing appropriately, yes, absolutely. So we have the weight part in there. Crying is significant of what? True. But more specifically, when do they cry? When they want something, exactly. It doesn't get too much better as they grow up. When they crap and when they're hungry, right? Because otherwise, if they're not doing that, what are they doing? They're sleeping. So obviously, we're not going to have too much of a productive life at this point. Everything is very premature. They're growing into it, that kind of thing. So they should be sleeping often. They shouldn't be moving too much. I mean, again, first month. So we maybe a little bit of the arms and moving of the head, but we're really not too worried about direct steady eye contact yet. So good. Hopefully Sean's watching. So first infant, 2 to 12 months for the infant stage. You can see that the weight is a little bit less of a concern, not a forgotten concern by any means. We want to make sure that they're continually growing, and crying generally happens, but you're also going to start to see the eyes. What do you notice about the eyes? More alert. Thank you. They're fixated, right? They're starting to go ahead and pick up figures and understand. Along with the other senses, they can sense when mom and dad are around or the regular provider, and they want to go ahead and ensure that these safe people, they're starting to go ahead and gain that cognizance about that. They might not know it's mommy and daddy, but they realize this is the people that are always around when they smell these certain things. Sleep is still there. Learning really begins, and there's that orientation around parents and loved ones. So he's going to take a quick picture of that to make sure he shows it to his teammate. I always put somebody in there. How are we going to treat these patients? And I don't mean ABC airways and stuff like that. We'll get to some of that. Excellent. Yes. Tactical care. Good. We're going to work with the parents, right? What else? How else? We going to talk to them like an adult? No, because they're not going to comprehend. You can get down on their level. Good. Yeah, I like it. A lot of our assessment is subjective information from mom, who's going to be, or dad, depending on who's there at the time when the incident occurs. Perfect. Excellent. Best poker face you can.
The more you start freaking out and getting amping up around them, the worse it's going to get.
You control the scene. 100% agree. So ensure, fake it till you make it applies a little bit here, because you don't want people to get overreactive. But we're going to keep them warm and dry. We're going to handle them gently, obviously. Anything regarding carrying and or putting them into some sort of apparatus, we want to be careful of that head and neck, right? Because how large is it in proportion to the rest of their body? We can even back it up a picture to take a peek, right? Pretty large in proportion. So we want to be cognizant of that. Speak to them gently, involve the caregivers. We got that. And here, foreign body airway obstruction or choking, it begins at 6 months and increases from there. So there is a part where it starts to dissipate, which is cool, but we'll see that as we progress. Take just a quick look on these bullets. When I start talking about care and treatment of the certain ages, I'm going to be looking for some of these types of responses as well as other specialty ones as the toddler, or I'm sorry, as they progress through these learning stages. Okay. And that doesn't seem to be working, but stand by. You remember where it said that they can begin to learn in this stage? Look at the eye contact. Look at the hands. I like my manhood, so I will not explain what the title of that clip is. But what did you notice? Did you see the hands? Did you see the eye contact? And when when she started talking to the male figure to the right, you saw a connection. That's going to happen later in that 12-month period. That said, did she just learn this stuff by herself? No, it's imitated. It's imitated. They're picking these things up and the brain is already starting to flow. So the title of the clip, and I didn't make this up, I just got sent it this way. It's Women Are Born This Way. I'm like, oh God. Yeah. So it's important to look at the articulation and the reassurance. She went to the male figure and he just kept on smiling and smiling and smiling. That's reaffirming. And then she looked over at whoever was videoing it and want to know what they were probably doing behind the camera, laughing their butt off. And so now she's coming back here. She's learning affirmation right here at a very, very young age. So a lot of things can be taught, as you'll soon find out. Toddler age. These are my twins. They were born in 2000, a couple months prior to that. So it's right at the 3-year-old mark. And what do we want to? Are we worried with weight with these guys so much? Okay, so maybe when it comes to, special circumstances a little bit, but they should be progressing. They should be getting their pediatric care by their pediatrician, what have you. They're probably not going to be very accessible to go ahead and lunge at when you're trying to evaluate. You probably have to work with the parents on that, especially if they have a specific injury, trauma, or medical. So what's that? Do not suffocate, yeah. They don't want to be suffocated. I think that stands for most patients, but I think it's generally speaking. Try not to huddle too much around them. Examine toes to head. Examine toes to head, right? We want to go ahead and gain confidence. And if we can get reassurance on the big toe and they know that this isn't going to be painful, maybe now we can start our approach up towards the head. So keep that in mind. Yes, box of stuffed animals on the engine. Yep. There's lots of different toys and other items that you can go ahead and gain a rapport. Have you ever had or seen that oxygen bear? It's a small little bear, and in the middle of its belly, it has all these little holes come out, and on the bottom, you actually put the end of the O2 tubing. So you can go ahead and turn it on via your regulator, and you can shoot it out the plastic bear. They think it's cute, and then they bring it up to their mouth, and you're doing blow-by. So that's one technique as well. But give it to them early, like a stuffed animal. You can gain a rapport. Yep. Try not suffocating. Obviously, removing their clothing and getting them separated is not a good idea. So keep that in mind. So here we go again. We want to keep them warm and dry, handle them gently. Putting things in their mouth is still a risk, but probably not as serious as it was within the first year. How do you want to talk to these patients? What's that? Oh, look at that. Yes, ma'am. Down on their level, which was also mentioned. Good. So, distracting them with toys or objects. Yep, absolutely. And avoid procedures on their dominant hand. It's just because instinctively they know they're starting to develop a lot of consistencies in what they're doing. Talking of which, my son was probably about 6 years old, so it's at the threshold of this. My youngest son, when he played hockey, and you have any hockey players in here? Yeah, so we're all righties, so I just automatically gave him a righty stick, and he kept on fumbling with it, and I tried and teach him, and he kept on fumbling with it, and I just couldn't get it, and I'm like, I don't know what's wrong with this kid, maybe he's not a hockey player. And then one day he grabs his friend's lefty stick, and he's like doing all the things with the puck, like at the age of 6, and I'm like, what the hell? So trying to figure out what their dominant hand is and what their side is still developmental at this stage. So 3 to 6, again, that's a little guy on the blanket that was there. Thinks that pain could be punishment. So, you know, he feels sorry that he may or may not have done something correctly. This is also that stage where they're trying to learn discipline, rights and wrongs. A lot of our values that we're teaching our kids will be understood at this age, but they're also pretty modest.
And tell Mommy again what you said you were going to do to him if he came here. Not nice. She will. Okay. Okay. But that's not a nice word. You should say kick his butt.
So it's a great example of modesty, but at the same point, I thought it was quite comical how the mother wasn't picking up on the fact that she lets this child watch so much TV that she learns it from the movies, right? That's what Casey said. And it just blows my mind that sometimes we can go ahead and inadvertently teach them this stuff. And the problem isn't about fighting, it's the word butt versus ass, right? I think we missed the message here. Yeah, exactly. So handling these patients, we want to keep them warm, use the caregivers, obviously, persistent crying inability. This will be a little bit easier to solve at this age. It's you want a toy, you want a piece of chocolate, something, and they usually calm down quick. But how else how do you want to talk to them? Involve them, I like that. You could use some simple words, absolutely. I think it'd be kind of obvious not to lie to them, but there's also something else we can do about talking to them. I'm sorry? Let them describe it. I thought you were almost there. Give them some choices and have them pick one for you. Give them a little bit of control. Would you like this this bear over here so we can go ahead and look at your arm, or are you just going to let us look at it? And obviously, you know what the choice is going to be for them, but point is now you're looking at the arm. Yeah, absolutely. Yeah, participant mentioned that, when you're going to auscultate, you give them the choice, front or back of the chest first. Excellent. Yep. A couple other items of importance. Still a low risk for foreign body. We already talked about the modesty and frightening or misleading comments. So maybe the inaccuracy of something that we were trying to explain might scare them because maybe they're big words. Okay. All right, 6 to 12, school age, fear of disfigurement, permanent injury. This is also at a gaming stage where they can continuously play video games and respawn and respawn and respawn. So they're understanding that people are dying because, you got beat at a game, but they're not connecting it with like they're able to come back. So death is something that they're trying to think of here. Keep them warm, speak with them. I'll be honest in procedures introducing pain. What kind of painful procedures would you potentially give a patient of this age? IV, yeah. What else? Yeah, CBG, blood glucose. Yeah, that's what I was thinking. It's definitely more common than an IV, but yep. Involve them in treatment just like the prior group. Reassure of body integrity. Ensure them that, nothing's going to happen that'll harm them more. And there's that deaths part. So we just kind of covered that as well. Good. 12 to 17, adolescents. We can start treating them as adults as quickly as we want them to get out. These are my twins, by the way. When this guy here on the right is that same guy, but that's our neighbor. And good old ages. So may desire to be addressed privately away from the parents, and I'm talking more at the 16, 17 years of age here. The biggest concern with this age group is what? Getting there. Sorry? Puberty? Pregnancy, puberty? Yeah, it's the whole entire understanding what our bodies are going through stage. And typically, they're not going to be very forthcoming about this. They might have one or two close friends that they're going to speak with in regards to what's going on in their life, but it's not going to be a regular public thing. The birds and the bees talks from the parents to the children typically happen right about this age group, which again is difficult to explain, but it is what it is. Experience 2 to 3 years spurts, but girls are typically done growing by 16, boys by 18. Obviously, and I mean height growing, not necessarily everything else, but that said, the sex drives start to develop and things become a little bit more dicey in their responses of honesty. So, those are them now, by the way. Well, gosh, sorry, that was their senior year in high school. That was 4 years ago. I better update that picture. Treating these types of patients, involve them whenever necessary, but explain things clearly and honestly, obviously. But this is what I also want to talk about. Consider possibilities, substance abuse, and discussions with parents. How easy is it to go ahead and start explaining? And again, it's easier for some than others, but you're all different age limits in this group. So how easy is it going to be for all of us to go ahead and start asking a young female that just within the first or second year of their menstrual cycle. When was your last menstrual cycle? When they complain of abdominal pain. It typically isn't something that flows right off the mouth, but again, with experience and time, it is for others, especially with genders. If they're the same, it might be a little bit more forthcoming. Use that to your advantage. If you don't have those people on your ambulance with you, you're gonna have to ask it. Are they gonna be honest about it? Are they gonna go ahead and say, I don't really wanna answer that, making them feel uncomfortable? Do you push it? No, not unless it's 100% relevant to the treatment that you're going to go ahead and administer. You don't necessarily have to. Yes, sir. It's really cool to have some. You got a little soft tone at the end. I didn't hear it. Correct. Absolutely. Absolutely. Having females on your team to discuss and or treat a young female is definitely a little bit more advisable than a super cool mustache older guy. Right. Yep. I love it. Let the online people enjoy it. So yeah. Could they be in a denial as well? So if things look like a duck and they sound like a duck, they may be a duck. 17-year-old goes into the hospital because she's having abdominal pain, comes with her grandmother because there's no mother or father in the picture. It's grandma taking care of her. And she's complaining of abdominal pain. So they say, okay, why don't you sit up on the table? And she waddles to the table. She's wearing a huge baggy hoodie sweatshirt, thank you. And they're like, okay, so how many months are you? And she's like, months of my what? She gets up on the table. They're trying to have this conversation, and the young lady is not going for it. The grandmother is like, she's not pregnant, not at all. So they went ahead, they ran a urine test. Obviously, you know what the result was. And they had to go in and explain to the 17-year-old, you are 7.5 months pregnant. That is the baby kicking as your abdominal pain. She couldn't believe it. She's looking over to grandmother. Her grandmother passes out, hits the floor. Now she's a patient. Okay. So if I didn't see it with my own eyes, I wouldn't believe it, or I would have to go ahead and tell you, I heard from my colleague, no, this stuff is real. And if they're potentially pregnant and they're not sure how to tell their folks yet, and they're in the first couple months, you can understand that they know they stopped menstruating, but at the same time, they don't know what to do next. And if that's where you come along into the equation, what are you going to reveal in front of the parents or not reveal in front of the parents? So it's awkward, but it's real. Let's talk about some anatomical differences between pediatrics and adults, because they're just small adults, aren't they? That answer would be no. Okay. No, kids are different. They're aliens. Yeah, they feel like it sometimes. Anatomical differences. Heads are typically larger, especially during infancy. I love the turkey timer comparison. If the turkey's done and it sticks out, the fontanelle's on the kid's head within the first year of life, you can go ahead and figure out if they have too much fluid or too little fluid. You'll see it go in and out, but it's a telltale sign. Keep an eye on that. Face is small in comparison to the face. To the head. You can see the disproportion of the size. That picture of Sean earlier, right? You saw that the belly was almost as large as the head during that 2 to 12 month period. So keep that in mind. And God forbid you have to lay the patient down for one reason or another. You might want to pad the shoulders so they don't stay in the sniffing position and their airway is more open. Tongue is going to be proportionally larger within the head as well, so that can cause a problem. When you guys, I know that we don't do this every day, but when you go ahead and stick an OPA into a young child, do you use any other associated tools to get it in? Or do you just stick it in like an adult? Nobody uses a tongue depressor? No? You weren't taught tongue depressor either? They're a great tool to have in the truck. So if you need to go ahead and stick an OPA in, their tongue's a lot larger and moves around a lot more. But a dry tongue depressor will actually, if you put it halfway in the mouth and then just push down you can pull up a little bit. The dryness of that tongue depressor will pull that tongue up off the back, and you can gently put the OPA in. So it's something that we do in New York. But food for thought, just to get it out of the way a little bit. Obviously, when you're coming down the neck and the airway, we're going to be worried about two specific respiratory problems, that one's an emergency and one's not. Which, remember what medical diagnoses I'm thinking of? Croup versus epiglottitis. Yeah, epiglottitis being that fast bacterial infection of epiglottis, where it will begin to swell and become an airway threat, versus croup, which is more of a viral infection bringing bronchitis or a bronchial type issue and a seal type cough. What's interesting is if you haven't encountered either one of these cases, is in scenario A with epiglottitis, the parents will be frantic and they will be, the baby and or the child will be a little dystonic. They won't be looking exactly at you. They'll be out in left field. They'll be drooling, versus the croup patient who might have a funky cough and seal bark like type cough, but they'll cough and they'll look at you, and then they'll look at their parents. And unless somebody causes pain to them, that's when they'll start crying. So you can see the image of both of those are two different threats. So was it somebody's pillow or their foot? So hyperflexion or extension of the neck can also cause an issue as well. Anatomical differences of the chest, things are still maturing in the thoracic cage. This bone that we have right here, the bones coming right around, it's still cartilage. It's not even hard cartilage yet. As they develop into the 15 to 18-year age limit, that's when it starts to calcify a little bit more to the adult bone of the rib. So these things are designed to expand in multiple ways and be very soft. Obviously, the muscles in between are very premature, which is why you see a lot of belly breathing or seesaw breathing within the gut and the lungs, that paradoxical movement. And of course, we also know that bradycardia is a sign of hypoxia, which could happen rapidly in this type of patient. So they're more diaphragmatic breathers, as I just kind of mentioned. And if they were to get struck, and I know we're looking at a picture of an infant here, but you can also imagine a 6-year-old or a 13-year-old. If they get struck in the chest, while this is developing and expanding, we don't know how quickly the lungs are developing and expanding inside. So if they're a little bit slower in the process, you're going to have more room in that thoracic cavity. So when they do get struck one way, shape, or form, it can easily cause a contusion or a little bit of blood contusion within the lung. That's a pulmonary contusion. All right, other anatomical differences of the abdomen. Again, a lot less protection here, even on us. Well, unless you're somebody like me gaining weight, then you might have a little bit more protection. But organs are closer together. Liver and spleen are proportionally larger and more vascular, so tend to more bleeding. But again, this area is all open range. Skin and extremities. If there's one thing that kids do, kids know how to fall. Okay, scrapes, bruises, all that fun stuff they will have. I was 15 years old when I think this is one of the reasons why I don't have a very good long-term memory. But when I was 15 years old, I was BMX biking it, if anybody remembers those years. And I went to this bike track. In order to go make a ramp in the middle of nowhere, and you have flat ground, you have to take the dirt here and pile it here to make your ramp. So my two cousins are in front of me. The first one flies right off of it. Second one goes off and he just clears the hole on the other side. And I was third. So I go up, I come down, the front wheel catches that little rivet. I go ass over tea kettle. I land completely on my face right here. There's not a scratch on me anywhere else but right here. I was walking around comatose from friend's house to friend's house, where mothers are giving me aspirin to get rid of the pain and the headache that I had. I was not crying. I was glazed over and appeared drunk. What does that tell you? So I didn't even know what drinking was at that point. So I woke up in the ER, don't remember any of this for the past like 10 hours. And the surgery is just them scrubbing the crap on all the dirt out of this because all the x-rays and everything was nothing. But huge concussion, didn't remember a lot of it. And I don't know, maybe it's something to this day that is a problem. But that said, that should have been more about the head injury than it should have been the scrapes and bruises. But sprains, strains, easily can be burned, large lost fluid and heat. Got to keep an eye on that. Respiratory wise, they have low O2 reserves. And we know that kids can crash quickly, but following their pulmonary circuit is something that we got to keep in mind. For an adult, our pulmonary circuit is pretty standard. We have a very high pressure system that goes ahead and squishes blood out of the heart, around the atria, aorta, all the way through and all the way down to our small little capillary in our big toe. And it starts the small little process back to our heart, nice and slow, sludging, all the way back to the vena cava, and then of course the right atrium. But that said, our blood pressure is what? 120 over 80, something higher, something lower. That's high pressure for our systems. What's the blood pressure of an infant? What'd you say? They're good? Yeah, looking at cat refill. Yeah, they're good. It's low. It's low. They don't have a, can you imagine on these maturing vessels that are like tissue paper within the infant, if we put a high pressure heart in there and said, go to have the same amount of pressure as an adult, it would push everything to smithereens, just blow everything up. Doesn't work. So how do we go ahead and feed the rest of the system? We increase the frequency and lower the pressure. Therefore, their resting heart rate is a hell of a lot faster than ours, but their blood pressure will be a lot lower because the more we circulate, the more we can reach all of those venules and vesicles and vasculature. So this is why they have a low pressure. However, because they have so much blood circulating around, they don't have too much stored up anywhere, cellular wise, and their aerobic respiration part, whatever they use, there's not going to be anything behind it. So if that cycle slows down, this is why we see bradycardia come quickly, and that's a significant sign that they're going to stop breathing. After they stop breathing, the heart stops beating, and you can see the cascade of terror, if you will. But that low O2 reserve is important to think about when we start talking about their shock and how long they're going to stay in compensated shock, which they're not very long, to decompensated shock, and then we have major problems. So this is why we want to get in front of pediatric treatment. Hypoxia develops, I just kind of explained this. I should have probably just put it up there, crash quickly. Got it? Good. All right, anatomical difference, cardiovascular system. I just explained this as well. You can read the slide if you want, or if I can give it to you as well. But again, smaller amount of blood. You know, we lose 300 milliliters of blood. We might be like, yeah, it is what it is. They lose 300 milliliters of blood. Whole different ballgame. Whole different ballgame. So carefully assess that as necessary. Look for those signs of blue modeling. Funny meme? Good? All right. Do you guys, I spent some time going through your protocols at lunchtime, and I saw, in this region, matter of fact, because I've been learning your different regions a little bit. In New York State, we have a statewide basic life support adult and pediatric treatment protocol. These are basic kind of things, and then the regions can actually specify even more to exactly what the regional physician wants. So I illustrate that to you because our pediatric trauma protocols was updated for the first time in like 20 years, 5 years ago. Like, did you forget something? So do you guys have a separate trauma protocol and or management protocol for pediatric children? No. Okay. So whatever is in your protocols, you'll see the child dose or whatever at the bottom of it, and that's it. Okay. All right. So not good, better, and different. I'm just asking. Oh, that's the determinant. Okay, we're going to talk about vital signs in a second. Good. So, and what's your first name again? Josh. Josh came out with a lot of interesting, good treatment protocols that you typically see in PALS, and we're going to reassure some of those today if you haven't taken the course. The first thing that you do when you walk in the room is you want to do a look test. You want to see where that child is. 9 times out of 10, you can say sick or not sick by looking at this child and determine if this is going to be a load and go or stay and play. Okay, and if you're not sure, that could be a stay and play. We're just going to have to get or attain more information. Interact with the family, figure out all the criteria that this child probably is not going to be able to articulate to you as you would the normal adult patient. Look for any responses from them. If they're able to answer any questions, that's great. And then, of course, look at the scene. Make sure that's safe. Somebody mentioned something about mandated reporter earlier. Yes, I'm not going to get into that, but I believe you guys all are, right? Yeah, I think every state's changed EMTs to do that. So good. Let me ask you something. If there's 4 of you on the call, do all 4 of you call? Seriously? Wow. No, yeah, I'm not arguing it. We have 62,000 certified responders in New York State. If we did that for every single time, they'd be out of a job. You just have to make sure somebody on your team call. So, and if nobody calls, you're all liable. That's our mandated reporter. So interesting. Look at the scene, see if there's any mechanism of illness or injury, and combat accordingly. We had a case in Syracuse, New York, where a 2-year-old died of methamphetamine overdose, because that's common at the sheriff's house. Yeah, he left cocaine out on the coffee table, and a 2-year-old got up there and ingested it. Yeah. Nope. Yep. Yeah, well, he was at the time. I don't know if he is anymore, but oh no, can't make this up. Can't make it up. Do your initial assessment. Look at the door. Look at the muscle tone. Look at that triage decision. I kind of mentioned this earlier as well. Moving on. This should be in your ambulance. The pediatric triangle is something that's very simple that we can all use. I laminate it and I put it in all our vehicles, and I suggest it to anybody and everybody that wants to listen. It is extremely valuable and very easy to go through. Looking at the airway and their appearance when you walk in that door. Remember when I told you, like, you can see sick or not sick when you walk into the door and you weren't sure and you could be a stay and play? You then apply this triangle. And if you see that the airway and the appearance appears abnormal, maybe they're not connecting with you eye to eye. Maybe the airway, you can hear snoring. That's a bad sign. But then, of course, you can understand what the good signs would look like. So, all right, let's just take it for what it's worth. A is okay. Let's go to breathing. Is it abnormal? Do they have increased nasal flaring, abdominal muscle use? Or is it normal where the breathing appears regular without excessive respiratory muscle effort? Okay, self-explanatory. It's like the A, B, and C's on the adult, only we're kind of visualizing it more versus doing hands-on. Yes, you can do auscultation in here, by the way. And then C, circulation. Look at the skin. Is it normal? Or are you looking at cyanosis, some modeling, partial pallor, or obvious, significant bleeding? When you see one of these kind of climb up there and you want to change your decision from stay and play to load and go, you can do that. You can change your decision tree from sick or not sick to the opposite. So this is very helpful in that. And then you can get into the rest of the assessment. Look at the vital signs for each individual age group. You have that memorized, right? I like his response. Yep, yeah. Why are we memorizing it? Because we want to impress the person next to us? Do we or do we not have devices in our hands that we can look this stuff up? Do we or do we not have protocols and or laminated covers that we can post right next to the pediatric triangle? That's 2 laminated items I'm asking if you want in your ambulance, so you don't even have to pull your phone out. Is it normal or not normal? If you're on the scene and everything's somewhat stable and you take a set of vital signs and you're like, crap, I don't know if that's good or bad, keep smiling. Get out to the ambulance and check your chart. There's nothing wrong with that, okay? You can tell if they're sick or not sick, and if they're really sick, you're gonna have more support there, for sure. So evaluate that, but these things are made for a reason. Utilize them. Don't memorize them. Continue with your physical exam, sample, detailed head to toe or toe to head, you know, depending upon their age, but work with that. Okay, one more important topic before we close. What is the #1 cause of death in infants and children? It's close. Trauma. You said falls, which falls under, you know, trauma. So very close. Who'd like that MCI? Quite problematic. Luckily, school buses are the safest thing, safer now than they ever have been. But depending on whether they make them wear their seatbelts or not, that can easily be prevented. So, really? Wow. I'll be honest, I have no idea whether they in New York too, but I know maybe it was back when I was a kid, they were telling us to wear a seatbelt. Somebody was telling me to wear a seatbelt. And yeah, I was just about to articulate that. I know there's other safety features besides the seatbelt that help decrease the risk, and the seating is one of them. What's that? No, most walls aren't. So, okay. So blunt trauma, again, missed it. Blunt trauma is also something that we got to think about. We have the whole abdominal region, which is kind of unprotected, and the thoracic region that's kind of still growing and maturing. So anything in here that we might have internal bleeding on, there's only one way to find out. CT, get them to the hospital, okay? You want to go ahead and see how that's working. But of course, suspecting it is always a good safety measure. Dying from airway ventilation is also something that we got to keep in mind. Just watch that airway. I think the gentleman in the middle mentioned something like that. Whoops. Might seem a small amount of blood, might be for more. I discussed that as well. More on blunt trauma. How were they restrained? There's a whole bunch of, how were they restrained in motor vehicle collisions? How are they restrained in our vehicles, which we're going to talk about real brisk. Falls, diving accidents, burns, sports-related injuries. Sports-related injuries is huge. You probably see that with a lot of the Boy Scouts that you mentioned that you were working with. A lot of outside activities. I'm already being called by summer camps looking for EMTs to go ahead and cover for sports-related games and basketball tournaments and what have you for the summer. So you can see how that's pretty relevant. And then, of course, child abuse. Here's this device. Who has one of these PD inmates in their ambulances? And then let me ask you, thank you. Let me ask you, do you guys have a law or policy requiring these in your ambulance? The state requires it? Okay. Okay. Yeah, no, some system rather than no system. Yeah. Do we have any child safety seat car technicians in the room? No. If your agency is doing any community service, that is one hell of a course that shows huge community outreach. However, it's a difficult course. And I don't mean difficult like test-wise. It's very rigorous. They get you into these cars, they make you sweat and put these car seats in properly. 90% of car seats installed without a technician are installed improperly. 90%, it's high. That said, kids aren't dying because they're improperly installed in a car as they are from the major blunt force trauma. This is a device that you can put onto the stretcher itself. In New York State, we're required to have the safety devices within the ambulance. If they're built into the captain's chair that comes down, that's satisfactory. If you install a child safety seat into the captain's seat or the side one, that's satisfactory. This particular device is highly suggested. There's other manufacturers with other brands, but I found this being one of the easiest. And I'm not advocating for one brand versus another, but I know that I've experimented with a whole bunch of them, and this one is quite easy. So if the Ferno guy's still here, he's probably gonna appreciate that. Burns, where's your nearest pediatric burn center? Portland? 3 hours away or an hour by flight? Okay. So 2 hours if you're driving. So not only is burns kind of difficult to see on a pediatric patient, but what else were you thinking on this? Swelling, yes. What else? Hypokalemia, abuse. Yeah. Who thinks this is an abuse case? Because like this age shouldn't be. Huh? Pulled something off the stove. Yeah. It does. It does. You can imagine this young child reaching up for the handle and pulling it down with, I'm assuming her left hand, right? And you can see it come down and look at this airway problem. Look at that airway problem. It was just a regular boiling pot of water that she grabbed the handle and it came down on her. Oh, they can investigate that, you know, they can investigate that. I'd like to think that nobody would like to do that, but you never know. Yeah. So good. Anything around the eyes, chest, feet, mouth, and arms is typically going to a pediatric burn center or a burn center that can take this pediatric patient. So think about flight as much as you can for these types of patients. Let's not waste too much time on their healing process and get them as comfortable as possible. Obviously for ALS, you're going to be looking at your pain management protocol and whatever you may have in the pediatric dose, consider that. In shock, remember, there could be other reasons when you're dealing with an infant patient that's going into shock, especially for trauma-related incident. There could be other reasons why they're already in some sort of shock. So adding the trauma shock on top of that could exacerbate the shock problem. And dehydration and diarrhea in a young infant or child is not uncommon on a regular basis. So then you put them in a car accident after that, you're wondering why they're decompensating so quickly. They've had pre-existing medical condition issues before that. Compensated versus decompensated, just to kind of give you a friendly reminder. Again, they won't spend too much time in the compensated area, but the decompensated, it's really going to be hard to come back. So stay in front of this. Medics, fluid them if necessary. And we talked about emergency care from the ABCs, C-spine precautions, O2, IV access if you have it, and keep them warm and transport. Not anything out of the ordinary. It shouldn't be anything really new. But that said, what else we got out of this? Oh, family response. I apologize. We talked about having multiple patients on scene for this. Coming in a good team where you can have somebody that near the parent's age articulate what's going on with this patient would be really good. And I say that because nothing against my younger population, but unless you're really good with words, how are you supposed to calm down a 30-year-old male or female paranoid parent? Have you done that before? Is it easy for you? So if you can do it, great. But I'm just saying, you might want to find somebody a little bit more their age to help communicate with that. If you're a parent and you can speak to this parent, home run, and remind them what can be done, will be done. No false hope, just what can be done, will be done. Work with them, have them hold the O2. Anybody use the paper cup trick for O2 use, blow by? Pop a hole in the bottom of a plastic or paper cup. What are the kids gonna do? They're gonna put it in their mouth. You just slip the O2 tubing in the bottom of it, turn it up to whatever you want. Now they are chewing on it and getting the blow by O2. So again, so like last class, we were talking about paper bags in your rigs. Now you could put paper cup. I'm kidding. So, so keeping these skills in front of you will give, if you go over this stuff and do these extra trainings more often, as the gentleman with the fancy mustache, I think, told me earlier before class, he said the more pediatric classes that you can take, the better you are at it. That's where we're coming from. That will lower that pucker factor. And again, when you're talking to the parents, keep that fake it till you make it face there. You set the tone. Do not go in there with a paranoid look despite the pucker factor, all right? Make sure you have a good response to them feel confident, reserved, and understand there's a lot of positive outcomes that come from pediatric calls. They're not all death, dying, and bad. They could be good. So that's my littlest with the twins. So thank you for your time.